immensely talented and skillful orthopedician, my close friend and colleague, Dr. Raju Mogaonkar. Great ambience of Taj and very nice hospitality by Cadila Pharmaceutical. So you will definitely have a great evening today. Outline of my talk is hypertension, the Indian scenario, history of blood pressure measurement, how is the guidelines for ambulatory blood pressure monitoring, various guidelines of hypertension, recent trials and how they have impacted our management, special cases of hypertension, CKD, diabetes, when to give long-acting antihypertensive molecule. These are the outlines. As far as the controversies are concerned, you know there are numerous guidelines which are available for hypertension. It's like ACCHA, there is a mother of all guidelines, that is JNC. There is a American Society of Hypertension, for which we have conducted lectures for the Physician Association for last 2 years, and now we have Indian Society of Hypertension, we have Diabetologist Society, Indian Diabetic Association. These all guidelines are there and they are quite confusing. We are sometime, stressed out what criteria needs to be applied to our patient. And immediately after publishing guidelines, then some major trial is done or some meta-analysis done, and that shows that the whatever guidelines have come up, these guidelines are not correct and you have to target this much blood pressure. First, what should be the target of blood pressure in a normal person with no other risk factors? Whether it is 140, whether it is 130, whether diastolic 80, whether diastolic 90, whether 150, that is one thing. Second thing is systolic, diastolic in diabetic population. Again, someone comes up with the guidelines saying that for kidney patients, the guidelines should be different. Someone says for kidney patient with albuminuria, guidelines should be different. So there are a lot of controversies. But what remains clear is hypertension is one of the major killer responsible for vascular event. So this is a gathering of around 30 people, 10 are surely hypertensive. That is very clear. So 1/3 of the population is hypertensive. Trends, they have shown that there is a remarkable increased prevalence of hypertension in the community, probably because of the lifestyle, because of the some changes into our genes which has occurred in last few years, maybe the diet responsible for that, and maybe the stress which we are dealing with. As far as the hypertension is concerned, the sad part in the studies have shown 50% of the hypertensive patients, they are not aware that they are hypertensive, and only 1/3 of them, they are treated, and only 1/5 of the patients have adequate, tightly controlled blood pressure. This is the sad part in India. And this is despite all the efforts, the awareness is very low. In last few years, I am witnessing significantly increased awareness among the patients, among the physicians, among the doctors also. 5 years back, the scenario was even a senior physician, which when I used to discuss, his views were like, this man is elderly, for him 160 systolic is okay. If we used to discuss among the physician community, the concept 10 years back was only diastolic which matters, and systolic is just a fluctuations of day-to-day life, and systolic hypertension does not have any role in myocardial infarctions or vascular event. The same thing is not true now. Now almost everyone is aware that it is systolic and diastolic. Both are important. Bringing down the blood pressure is very important. Bringing down the blood pressure to a target level, below the target level, is very important. As far as the history is concerned, the first time when the blood pressure was checked, that was in the horse carotid was cannulated, it was connected to a brass pipe and a goose of a trachea, and the blood pressure was measured by the height of the blood column which was flowing up. Quite an invasive mercury manometer was used, but again that was an invasive and connected to the artery as such. This was the man, an Italian physician, Raiva Rocchi, He discovered the sphygmomanometer, where the rubber sleeve was used to squeeze the artery with the pressure bulb, and that inflated, squeezed rubber sleeve used to help us to calculate the blood pressure, and we use it. It has been said that even a general practitioner, for a patient coming to him or her for any complaint, he should take the blood pressure. Few orthopedicians are here in the gathering, so forget about them. But all of us, even if a patient coming to us for back pain, abdominal pain, some leg pain, headache, do not forget to check the blood pressure, because it is a integral part of the examination. Many our hypertensive patients are silently hypertensive and silently getting their organs damaged without their awareness. So check the blood pressure is very important. And the sad part is, the father of hypertension, Norman Kaplan, says this is the most easy investigation, this is the most needed test which should be performed, and it is performed in the most slopiest manner. So you will agree with me when we check the ideal guidelines, Indian ideal guidelines, how to check the blood pressure. We have to check the blood pressure, we have to take 2 to 3 readings at an interval of 2 to 3 minutes. We are very busy, most often than not we hurriedly take the blood pressure, so, and we never take it again at the end of examination. I would recommend, and I have already made a practice for last many years, that we check it, I myself check it twice, to begin with and at the end of examination. You will find that there is a difference of 6 to 8 millimeter of mercury. Very common, because by the time you start consulting the patient, ask him to take deep breath, examine CVTS and RS, CVS and RS examination, and he becomes familiar to you, the blood pressure starts coming down, and that is the ideal blood pressure. Patient should not have smoked tea, coffee. He should not have a heavy exercise done in last 30 minutes. What happens? He has to catch a cardiologist. He runs, he climbs staircase. He is aware that this man will be again busy in the cath lab. He will hurriedly reach to you, and you are taking his blood pressure in a very rapid manner. So that's not an ideal. Allow the patient to sit comfortably in a quiet room. Take the blood pressure mostly in a sitting position. If he's a right-handed, then right arm, left-handed, then left arm. Whenever you are examining patient for the first time, take bilateral blood pressures, both arm blood pressures, and mention it on the paper. The blood pressure which is higher should be considered as the normal blood pressure. Right-handed person has little high blood pressure on the right hand, left-handed person is having little high blood pressure on the left hand. It is because of the increased muscle girth, because of frequent use of that hand. And this is all basic findings which we have to do. And if we do not follow this, see the errors what it can produce. If person is not sitting or taken a proper rest, his blood pressure can be as high as 12 millimeter of mercury. If the blood pressure is not taken in a perfectly sitting position with back support, there will be an error. The BP apparatus, that cuff needs to be tied properly. It has to be above the elbow crease. The cuff size has to be proper. Like if someone is very obese and you are using the same cuff size, then that cuff needs to inflate more and more in order to, squeeze the brachial artery. So what will happen? The blood pressure which is you are calculating is spuriously high. Similarly, if someone is a thin built and you are using the regular cuff, that cuff is with less blood pressure, it will give you the systolic blood pressure. So the cuff size has to be adequate. You have to take blood pressures, multiple readings need to be taken. And another important thing which is very common, that you have to finish up your consultation, you keep asking the questions to the patient while you are checking the blood pressure. He also keeps on talking to you. Very often it is seen, he keeps on talking, particularly if he is she, then if she keeps on talking that when I come to the doctor the blood pressure increases, मुझे बहुत घबराहट होती है, मुझे डर लगता है, मी फार घाबरून जाते, माझं blood pressure इथे आल्यानंतर वाढतं, and you are checking the blood pressure, she is repeatedly saying the same thing. So just ask her to calm down, take the blood pressure when the patient is not talking. Now in last 3-4 years, We have a lot of lectures on this. So it's just in rebrushing, ambulatory blood pressure monitoring, now considered as an important tool in the diagnosis, in the management of hypertension, and frequent use of ambulatory blood pressure monitoring as and when required, as and when needed, should be indicated. It is just like you all are aware, it's a pocket-like thing which is attached to the body, and chest leads are kept, and patient's blood pressure is monitored half an hourly at the daytime and 1 hourly in the night time. So it helps. Various indications are there, particularly when someone is having borderline hypertension, that sometimes blood pressure is high, many times it is not high. So you can just hook up the ambulatory blood pressure monitoring and see the day-to-day variation of 24 hours, and you'll come to know. White coat hypertension is a very important entity which all of us know, that patient visits doctor, or remember, patient visits a stressful situation. The blood pressure is high. It may be his office. It may be in front of his boss. It may be in some, if he is a surgeon, is performing some case. So it is like white coat hypertension is detected in a stressful situation. So remember, this white coat hypertension is previously thought to be a benign entity, is not a benign entity. 1/3 of white coat hypertensive patients, they turn to be hypertensive in future because they have a tendency to develop hypertension, established hypertension in future. But remember, this white coat hypertension needs to be managed, diagnosed, and very easy way is ambulatory blood pressure monitoring. In hospital, patient's blood pressure is high. When he goes home, blood pressure low. So doctor starts treatment, patient start getting giddiness, and he comes back to you and say that when I take that tablet, I feel dizzy, I feel giddy, weakness, profound weakness, sleepy in the afternoon. So there is some side effect of this tablet. You check the blood pressure is again high. You increase the dose and he starts getting symptom of hypotension. Isolated systolic hypertension is also a common entity. Nocturnal blood pressure is something which we as a physician cannot diagnose because it is only diagnosed with ambulatory blood pressure monitoring. You can't go to patient's home in the night and check the blood pressure, and if you go and check the blood pressure, patient will again get up, so that is not an ideal. So nocturnal blood pressure, normally at night the blood pressure should drop down below 120 systolic and below 70 diastolic. If someone is dropping less than that, he is less dipper. If someone is not dropping and remaining at 140, 90, 130, 80, he is non-dipper. And someone whose blood pressures are increasing in the night is paradoxical dipper. All these non-dippers, less dipper, paradoxical dippers are prone for next day morning event. So circadian variation, you might be aware that there are increased incidences of vascular events in the early morning hours. And those who have increased incidences of vascular events in the early morning hours, they are found to have non-dippers. They are found to have nocturnal rise in blood pressure because at night the blood pressure normally should drop down. If it is increasing, that is a dangerous sign. Resistant hypertension, you know, if 3 or more than 3 antihypertensive tablets, when they are given in adequate doses, one of it is diuretic and still the blood pressure is not up to the target, we consider it as a resistant hypertension. Hook up ambulatory blood pressure monitor, that will give you a lot of information. Patient's blood pressure may be absolutely normal. Whatever you are seeing is an element of white coat hypertension in resistant hypertension. So there is no need to add fourth molecule. Or patient's blood pressure are increased in a particular span of few hours in 24 hours. Just add a short acting molecule hour or two prior to that, and 24-hour blood pressure is smoothly controlled. Patient's blood pressure may be very high in the morning and low in the night. Adjust the dosing schedule and the resistant hypertension will be managed. Hypotensive symptoms will also be detected on the ambulatory blood pressure monitoring. As I told you, as far as the ABPM is concerned, ideally the blood pressure should be less than 130/80 when ambulatory blood pressure monitor. Usual criteria is 140/90, but 140/90 is for office, 135/85 for the home blood pressure monitoring by self or family physician, but ambulatory blood pressure monitoring, it is 130/80, and in the night it should be less than 120/70. Limitations of ambulatory blood pressure monitoring, my colleague will agree, it is little cumbersome. we have fitted to many of our colleagues at Dhoot Hospital, and the only complaint is कि it's very cumbersome. रात को नींद नहीं आई, रात भर वो दबाते रहा एक एक घंटे को. It's little cumbersome, costly, 24-hour measurement, but useful and needs to be used properly. Guidelines of hypertension, similarities and differences. As I told you, mother of all guidelines is JNC, and JNC has clearly mentioned now it is a relaxation for all we physician that 140/90 for less than 60 years and 150/90 for more than 60 years. So more than 60 years, 150 is a criteria, has reduced at least 2 to 3 medicines for this patient. So it is a little liberty for us, because it is very difficult for a 70-year man to bring down blood pressure from 150 to 140. You need to increase doses of molecules, add side effects of that, you need to increase the cost, but now it has been decided 150/90. The similar criteria is there for most of the criteria committee. As far as the beta blockers is concerned, as an initial line of treatment, first line of treatment, now it is big no for all criteria, and that controversy is practically over. European Society of Hypertension and Indian Society of Hypertension has recommended cardioselective beta blockers at the discretion of a physician as a first line treatment when associated conditions warrant it, when they think that it is appropriate. Otherwise, beta blockers is a big no. Whenever the blood pressure is more than 20 millimeter of mercury systolic high or more than 10 millimeter of mercury diastolic high, start with 2 drugs straight away. If the systolic blood pressure is more than 30 millimeter high and diastolic more than 2, you can start with a triple drug combination which is approved by US FDA guidelines. So as far as the younger patients, if we have A, ACE inhibitor or ARB, B, beta blocker, C, calcium channel blocker, D, diuretic. Start with A. A is usually the treatment of choice. In elderly population, as you know, it's atherosclerosed, sclerosed vessel, wide pulse pressure, more systolic blood pressure, less diastolic blood pressure. Apart from the stringent non-pharmacological measures of salt restriction, diet and exercise, it is the calcium channel blocker or a low dose diuretic that helps in that patient to bringing down the systolic blood pressure. Younger patient, if you have started with A, in metabolic syndrome like India, it is better to add C, because that helps in a combination. A and calcium channel blocker, long-acting molecules, they help to bring down the blood pressure. If by some reason you have to add second molecule, not C, then think of a D as a diuretic. So either you have to start with A, add C or D. If you have added C, then add D. If you have added D, then add C. And if all the three things are there, A, C and D, still the blood pressure is not controlled, then if there is no contraindication, you can think of cardioselective beta blocker B, or you can think of potassium sparing diuretic spironolactone or an alpha blocker, which is helpful in such condition. So this is the usual guidelines. Now the consensus is now clear. Most of the guidelines suggest start with A in younger patient, add C or D, add D if C is added. Consider beta blocker at the end, at the 4th or 5th line in the management. As far as the polypill is concerned, you will agree the compliance issue is too much, because these hypertensive patients, they have metabolic syndrome, they are diabetic, they have dyslipidemia. Many of them, they have suffered vascular event, they have some kidney related trouble. So they are going to consume number of tablets, and it is very difficult. You will agree with me, it is very, very difficult to keep pace with our life and keep taking the tablets at regular time. So that is the main purpose of starting with the polypill. I myself have prescribed 1 month course of 3 times a day some abdominal pain related tablet. So actually he has prescribed 90 tablets. Today is the 20th day. So ideally I should finish up 60 tablets. I counted today, I could take only 18. So it is very difficult to remember to give tablet, to take tablets regularly. So that's why the polypill concept is there, and that polypill improves the compliance. Only thing is that remember it is still not the, ongoing clinical trials are going on. Tips 1 and Tips 2 released, that has clearly mentioned that compliance issue is taken care of and pocket is been taken care of. Tips 3 will give us a idea about the concept of polypill. Always remember, when the multiple combination medicines are used, you have to doubly sure this bioavailability of the medicine into the bloodstream. It is very, very important. Remember, all these molecules, they keep on having interactions with each other. Pharmacokinetic of one molecule is not equal to another molecule. Half-life of one molecule is not equal to another molecule. These pellets which are given, they have some different tablets inside a capsule. They have some granules inside the capsule. We have to make sure that this is being taken. Then the blood investigation should clearly mention the tough and peak ratio of these molecules proper. Then only these polypills will have a future. And always remember, a molecule has to be combined in such a way that they should synergistically increase their action and reduce each other's side effect, nullify each other's side effect. They should be biocompatible, is very, very important thing. So Indian hypertension guidelines have recommended that cardioselective beta blockers can be used in young hypertensive with specific indications at the discretion of a physician. And we are quite aware now that the chlorthalidone has almost replaced hydrochlorothiazide. It is metabolic friendly and seem to be useful diuretic. As far as we know, this was the major jolt for the beta blocker. We prescribed attain, tinolol, tinormin, tinoric for decades together, and suddenly the life study came in 2002, and it was like a big jolt that beta blocker not reduces vascular event. Beta blocker, though control the blood pressure, they increases vascular event paradoxically because of its metabolic side effects. And this then further proved with another trials, and so the beta blockers went back. Now again, when someone has said JNC released and JNC said 140 and 150 criteria for younger and elder population, again few landmark trials have come and they have tried whether we are chasing too low. Can we bring down the blood pressure too low? Sprint trial was the trial, a mega trial, which was tried with in non-diabetic population to bring down the blood pressure aggressively, intensively, below 120, and see whether the persons, those whose blood pressure have brought down below 120, do fairly well than the persons whose blood pressure has brought down below 140. So an intensive arm was compared with a standard arm. It has been showed that there is a definite benefit as far as the vascular events are concerned. There is a 25% lower risk, but for that purpose you have to treat 61 patients aggressively to reduce one vascular event. So that is number needed to treat. So 61 patients blood pressure should be brought down by more 20 millimeter more mercury. Then there will be one vascular event will be prevented, and it is at the cost of too many side effects of hypertension. An important side effect was a renal failure and acute kidney injury. You can see the p-value of less than 0.001. So it's a quite significant p-value. So sprint conclusion, it is beneficial, but we have to be careful and side effect profile is low. Again, after the sprint, then another trial came, that is HOPE 3. Last April, I was in Chicago when this trial was released, when I was felicitated with FSCC. So this HOPE 3 was having multiple arms, like here the intermediate risk population was taken. In HOPE 1, HOPE trial, high risk population was taken. Here intermediate risk population was taken. Few were normotensive, few were hypertensive. All were given statins, all were given candesartan and hydrochlorothiazide. Normotensives also, hypertensives also. And all were given rosuvastatin 10 milligram. It has been observed for all subgroups, rosuvastatin 10 milligram did very well as far as the reduction of vascular events is concerned. So intermediate risk, high risk, we are quite aware. We are using statins to all of them. Proved vascular patients, we are using statins unless contraindicated. But now intermediate risk, HOPE 3 has shown that rosuvastatin 10 milligram is helpful in prevention of vascular events. The same thing was not true for hypertensive, antihypertensive molecule. Because when candesartan and hydrochlorothiazide was used, candesartan and hydrochlorothiazide brought down the blood pressure significantly, but it was not reflected into the reduction of vascular events. On the contrary, there was an increased side effect of the molecule. Only in the subgroup where rosuvastatin was used along with candesartan and hydrochlorothiazide, that too those were hypertensive, they got the benefit. Probably that was because of the reduction in the blood pressure. So it is reduction in the digits that matters, and that bringing down the blood pressure in hypertensive population with candesartan hydrochlorothiazide along with rosuvastatin helped, but normotensive it didn't help. But all pressure groups rosuvastatin helped. So this was the HOPE 3 trial. So there was no significant benefit in that arm. These trials, they have categorically mentioned very seriously about how to check the blood pressure. They have given a great emphasis on that. So this trial again contradicts lower is the better hypothesis. So again the value is what cutoff mark is 140. So the controversy which erupted after JNC, like everyone was saying, the stroke incidence is increased after the JNC has liberally released the criteria to 140 and 150. We should bring it down further. So that is again nullified with that. The same thing is true for accord BP. Diabetologists are here in the population. The diabetic population was tried, and the accord also suggested that the goal should be 140 for the diabetics and 90 for the diastolic diabetic patient, and not too low. KDIGO, that is a kidney patient's trial, and that has also mentioned for kidney patients 140, 90. For those who are having albuminuria, it should be 130 and 80. Otherwise, it is again 140 by 90. Now, this is again a controversy. This is a controversy. We are using a 24-hour long-acting molecule. Whatever time we use it, how does it makes a difference? Whether we take it in the morning, whether we take it in the evening. I prefer to give to my patient in the morning because it's easy to remember. Patient is at home. Too many persons, particularly spouse, is accompanying. She can give it with tea also, and it is a convenient time where it can be given. Once we start our work, it is difficult to remember. We go at various places. It is not possible to remember in the afternoon or evening hours. So morning is usually preferred, but the most of the trials nowadays suggesting that when a long-acting molecule is used, evening should be a better molecule. But still there are few trials going on, like Time and Hygia trial, which will be released in 2019 and 2020, which will give us an idea exactly what should be the timing of a particular molecule when it is given, antihypertensive molecule in a daytime when it is given, whether it is a morning, whether it is afternoon, whether it is evening, or whether it is at the time of sleep. So at the end, when we are seeing lot of controversies, now we are almost aware of the consensus. We are now fairly aware about the targets, special populations, and the targets among them. So hypertension, as you know, is a common entity. Blood pressure needs to be properly taken. Ambulatory blood pressures should be taken as and when required. Multiple trials, they are there. The criterias, goals, again for younger patient 140, 90, elder patient 150, 90. Below that, diabetic patient, you can target 140 and 85. For albuminuric patient, you can target 130 and 80. No, too low is not good. Bringing down the blood pressure too low is not good. Last year we had Dr. Krikshang with us in the physicians meeting. He is actually the first person to suggest that bringing down too low increases the mortality. J curve of hypertension. Actually, that is a J curve of Krikshang's J curve of hypertension. We had a lot of hot debate a few months back when he was here in Aurangabad. So that too low is not good. We have to bring it down adequately only. Choice of drug needs to be individualized, but the criteria have clearly mentioned which is superior for which group. And till the data comes, it is your decision whether it is a evening or morning dose for a long-acting antihypertensive molecule. We Indians now coming up with various studies and various criteria. As Indian Society of Hypertension is quite active. I myself is a member of that, and we are coming up with the criteria. We should have more studies, more our own literature rather than relying the literature on the Western population. Huge diverse population we Indians have, and ethnicity and race and the caste and religion. So it could be different for South India, it could be different from West India. We should formulate our own criterias, but till then we have to rely on the Western data. So this was all about multiple controversies, multiple drugs, multiple regimes, which one to start, what should be targeted, what should be the timing. And this is probably the present consensus after multiple guidelines and the final consensus which we can draw. Thank you. Yes, sir. Yeah. 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 Right.
How would you manage it?
Yeah.
It's on the borderline, 70, 80, and systolic is about 180 or 200.
Yeah. This is one of the common scenario which is seen particularly in the elderly population where the vessels are sclerosed, and when the vessels are sclerosed and rigid, there is a wide pulse pressure. Systolic increases and diastolic does not increase, or diastolic remains normal. Now if you try and bring down the systolic blood pressure, diastolic also goes down. This is a very common thing, and it has been observed that if you bring down diastolic too low, at least coronary vascular events are increased. Not cerebrovascular, but the coronary vascular events are increased. So that is the problem. So in such situation, it is very important to target the systolic blood pressure. Bringing down systolic blood pressure is that way easy than diastolic blood pressure, because systolic is determined by various controllable factors. Diastolic is vessel stiffness as such. If you are targeting systolic blood pressure, bring down the salt intake of the patient, which is very, very important. Rule out that isolated systolic hypertension is not white coat hypertension. It is possible 10 to 20% of your patient's blood pressure, systolic blood pressure, may be normal at home. So that is one thing. Salt restriction is remarkable important criteria in such wide pulse pressure patients. If you have to start a molecule, start with calcium channel blockers. Long-acting non-dihydropyridine calcium channel blockers specifically targets more on the systolic than on the diastolic, and add a diuretic, chlorthalidone, in such group. Always keep a watch on the diastolic pressure. Always strengthen the non-pharmacological measures in each and every visit. So that will help to bring down the systolic without bringing the diastolic below 60. If you are creating a diastolic above 60, then it's okay. And most of the time than not, you are successful in bringing down the systolic blood pressure with strengthening non-pharmacological measures, using judiciously calcium channel blockers and diuretics, and as and when adding the A component to it, ACE inhibitor or ARB.
It's for the beta blockers.
Yeah.
In the pathophysiology of hypertension, sympathetic overactivation and renin-angiotensin system, these two major mechanisms are operating. Which one comes first, sympathetic overactivation or renin-angiotensin system? Because it is said that sympathetic overactivation comes first, then renin-angiotensin system. And when it comes to the use of beta blockers, particularly in the younger hypertensive use, what will be your choice in such cases?
Yeah. It is like, again,
shall we continue antihypertensive, or we should wait, or is it like stress diabetes, it was stress hypertension?
right. Not an uncommon situation. By and large, this happens like, rather than this happens in this way, like the patient is taking 3 tablets, he has skipped all 3, and he come back to you with some headache or some non-specific complaint, and you will find the blood pressure marginally elevated. And when you have started the tablet, you required multiple tablets to bring down the blood pressure significantly, and somehow you could manage at that time, and now he is off the tablet and still the blood pressure is near normal. So this is not an uncommon situation. Various things, they work together for that. It is like, most of the molecules, they are long acting molecules. They keep on having their some action into the bloodstream for weeks together. That is one thing. Some lifestyle modifications, some other measures, and one another thing is, you have started with one thing, added second thing, and then you have put on third thing to bring down the blood pressure. Probably first and second thing was not enough for his body, and the best molecule was third. That has brought down the blood pressure significantly. So though he was on multiple molecules, his probably the treatment of choice for his body was a third molecule, and that was taken off, and that is still having some action in the bloodstream. In such case, you again call the patient again if his blood pressure is normal. You discuss with him that this is possible, that your blood pressure will increase subsequently after few days. That is possible. Second, in such case, you can hook up ambulatory blood pressure monitor. It is possible that many of the time in his day, 24-hour day and night, his blood pressures may be high. And in such situation, you should start reverse the way your prescriptions were. 1, 2, 3, 3, 2, 1.
Non-dippers and something like that. Giving the doses in the morning hours, any of the ARBs, it's not necessary that they will be going to cover for 24 hours. And most of the vascular events are in the morning hours. So calcium channel blockers, we have seen that there are certain preparations which are 24 hours working, not more than 12 hours working. When it comes to ARBs, or even ACE inhibitors also, they don't cover for 24 hours. In those scenarios, giving morning dose is good, or giving evening hours dose is good.
Yeah. So that's why the recommendation of evening is coming up. A very important thing is that hypertensive people, they are non-dippers. It is very common. Like if we check the ambulatory blood pressure monitoring of a normal person, you will have a normal variation. But the hypertensive, they will either not drop in the night, or they will drop less in the night. Sometimes they may have increased blood pressure in the night. So that's why they have a morning vascular events, as you have rightly said. So that is the main phenomenon, that is the main theory which is telling us that you should take the blood pressure in the night before going to the blood pressure pill in the night before going to the sleep. So here also there is again a role of ambulatory blood pressure monitoring. And now, as you have said, but ACE inhibitors, yes, I agree, but ARBs, telmisartan has a 24-hour action, olmesartan has a 24-hour action, and the action of losartan, which used to reduce in last 4 to 6 hours, is not that true, and peak to trough ratio of these molecules is ideal as per the requirement of the antihypertensive molecule into the bloodstream, that they also drop their action in the night hours, and that with these newer molecules. Yeah, losartan does not have 24 hours action. Doesn't have. That is true. Losartan is, the action starts waning after 16 hours. After 20 hours, practically there is nothing in the bloodstream. But better to switch over to another molecule, unless there is a compelling indication of uricosuric action which is required for losartan or cost for the losartan.
Not good compliance with most of our Indian.
Yeah, that is true. Thank you.